Saucier back with you, host of Cycle Power Summit 2019, and I'm here in this session with Dr. Lynn Keenan. Dr. Keenan is Vice President of the International Institute of Restorative Reproductive Medicine and has served on the board for the last 10 years. She's a professor of medicine at University of California, San Francisco, Fresno. Is that right? Okay.
We're at Fresno branch.
Okay, Fresno branch, where she has been faculty for 25 years and is program director for the Sleep Medicine Fellowship Program. Dr. Keenan, it is such an honor to have you here. Welcome to the Cycle Power Summit.
Oh, thank you so much for having me. Just really excited to talk about this new field that we're trying to develop that I think is so needed.
Yes, absolutely. And so the focus of our conversation is going to introduce this concept to this concept of restorative reproductive medicine and how it's different from the reproductive health care that many of us are used to. What does that look like?
Yeah. And so really, I think we need to kind of take a step back, and every field of medicine besides the current reproductive health care really digs into the physiology of the patient and tries to figure out what's wrong and tries to return them to the natural healthy state. But then you have the current reproductive health care where you take a healthy woman and you try to break one of her healthy systems. So the whole approach is just so different than every other area of medicine. So restorative reproductive medicine is where we're trying to really go back to what we do with every other system, is really, we start with, teaching the woman to chart. That's just so essential. And we become a partner with the woman to chart her cycle. And then when we do that, I love seeing them back the first couple of times because, I say, we're going to make you an expert in your own body, and together we're going to collaborate to figure out what's wrong. And so when especially when you're teaching teens, they come back with you can see their self-esteem as higher, and they can see with what beauty that they were created and how this complex system, you can just unravel the pieces in the puzzle work when you start to chart. But then, that chart guides us so we can see what's wrong rather than just covering it up with a pill, which certainly makes everything kind of flatline. We see what the woman's body is telling us. So we can see evidence of disease or, stress, and then we can guide that, our workup by what we see on the chart. So, if we see long cycles, it may be a different workup than someone with no mucus or someone with a short post-peak phase. And so regardless of what method they're charting, the physiology is the same. So the restorative reproductive medicine, just like any other field of medicine, we're not like branded, we're like an umbrella for the whole field to work together, to challenge each other, to grow in research, to collaborate, to build on each other's knowledge so that we can really improve the access worldwide to this type of healthcare, which again is really just standard healthcare if we consider any other system.
Right. So you used, when you were comparing the two, used the term breaking the system, or I want to clarify this for people and the differences, it being that, and you can speak to this more, Dr. Keenan, but that for a lot of reproductive conditions are treated right now with hormonal contraceptives.
Yes. Right. And so that is what I meant by kind of breaking the system, is it really overrides the woman's own hormones. And by giving this high dose potency of hormonal contraception, which is 5 to 10 times more potent than what the body makes. So it's not just bringing them back to the normal state, it's really suppressing her body and overriding it with the synthetic hormones. And so by doing that, you haven't corrected the underlying problem. You've really just put a Band-Aid. And I think the Band-Aid goes in so many different directions, that metaphor, because in addition to the woman saying, oh, now I've got regular cycles, but it seems like doctors in training, it's like, oh, put them on the pill and things are normal, and they don't dig deeper. And also the woman's physiology that's trying to be shown in those charts, if we just really took a better history and we got those charts month after month, it would tell us so much information that's just being covered up. And so then the research into that is being covered up.
Right. Yeah, that's a great point. That not only is there a problem with just treating the symptom, but that we're covering up that data or that communication that the body is trying to get out there, right?
Right. It's like this area should have so much extensive research by now, but it's all been kind of channeled in other directions, which pill works the best, or which one maybe causes fewer heart attacks. Not any of them don't cause any heart attacks, but just which one causes fewer. which one harms the woman least. It's taking a healthy woman, giving her a pill for something that's not a disease, causing harm. And then the whole culture has said, well, that's good enough. It's an acceptable risk. And so just causing women harm for something that's not a disease, it's just amazing that so many women accept that. And I think they accept it because they don't understand that there's really better choices.
Right. So that's what we're working on. And it is amazing how much progress is being made right now. So can you talk a little bit about some of the conditions or disorders or problems that are considered reproductive abnormalities and that could be helped by restorative reproductive medicine approach?
Yeah, because there's the common ones that a lot of people seek this out when they're having trouble with infertility and when they want a different approach. So certainly when we see that, and there's those different markers in the chart, like no mucus, really long cycles, really short post-peak with a recurrent miscarriage. But then there's also the things like the PCOS, which has such a classic pattern that you can pick that up in the charting. And then for some, it says it's like PMS, it's their mood disorder. I've had a woman that was actually diagnosed with bipolar. She goes, but I really thought it was my cycle. We fixed the cycle because she tried bipolar meds and actually gave her kidney failure. So was really harmed by it. And then when she found she was using the Creighton method, when she started charting, fixed the hormones, it smoothed out her mood and everything was better. So like they totally missed the diagnosis. So PMS I think is a really important one. And so for some, it's just those premenstrual migraines, or I'm in sleep. I've had women that have just premenstrual sleepwalking. And so when we actually corrected their hormones, that got better. And so it's such a tip of the iceberg. It's like so much has to be explored on areas that we have no idea that it's impacted by the hormones, because people are thinking it's a whole different disease. Like, again, since I come from sleep, I've had women with narcolepsy. Women with narcolepsy, a lot of times it's autoimmune based. And then, autoimmune based problems also can reflect in the cycle. And I had this woman come in and she was charting and she came into me with narcolepsy. And when we fixed her chart, her narcolepsy actually got better. And we saw this pattern, this kind of unusual pattern that I've since been starting to do some research in the reproductive health of women with narcolepsy. So again, it's like it opens up these new avenues that nobody's been looking at. But the classic ones that we would be seeing would be like the infertility, recurrent miscarriage, unusual bleeding, which has a whole list of causes. It could be infection, it could be autoimmune, it could be thyroid, it could be cancer, all the things that red flag just tells us dig deeper, find the answer, rather than covering it up.
But that's fascinating. Not only these disorders that actually have names, but just having trouble sleeping, or some of the other things that you mentioned. That this is all connected. When you talk about this, a bipolar like brain disorder that we think of as just up here,
right?
But then it can be all connected with down here where we have babies.
Right. Yeah, and it's like such a reflection, those charts. I do think that they probably misdiagnosed her, but they just didn't understand it was only one part of her cycle. And so I think it leads to just better healthcare for women in many different ways, not just infertility.
Yeah.
Or not just family planning. So many people think of, use NFP to find your fertile times to avoid. And it's like, okay, that works. That's only the tip of the iceberg.
Yeah, well, and I like to think even that we're charting cycles for health first. And then if you want to use it for family planning, that's an option too. Cool.
Exactly. Yeah. Exactly.
You've mentioned the cycle charting a few times. Can you talk about even logistics? Like these doctors who practice restorative reproductive medicine, do they learn how to read these charts? I mean, I know there are women who have charted on apps or maybe done some basic charting before, but can you talk about how that happens? They chart their cycle and then they can actually bring it to the doctor, and then what?
Right. So most of the doctors that do RM are trained in one specific method, and then they start to look at other methods just because all different women will come to them. So they have to be well-versed at the different charts. So definitely the women bring the charts, and sometimes they'll come to them like with infertility and they've never learned how to chart. So maybe it's the doctor suggesting that they go find a teacher, but it kind of goes both ways. But that chart is just so important because that's the basis for just that initial, it's kind of like the EKG for the cardiologist. You just need kind of some of the basics. What is it telling us? So where are we going to go with our differential? Where are we going to go with the next step of evaluation? And then as we implement treatment, then we can see, okay, does it look like it's getting better? Because it gives us this beautiful feedback. You know, every day, a woman's hormone, just the combination of the different hormones is different every single day. And obviously we cannot be drawing labs every day, but we don't even need to when we have the charts. We get select labs to kind of confirm, but it's just such a wealth of data. And so again, a lot of the doctors that do this are really comfortable with one, but what we try to really encourage is that they get comfortable with all of them. So it's not method specific, it's a whole field of science that we pull together our resources.
Yeah, excellent. And so I just want to recap for our attendees listening. So for me, I love analogies. So if we're looking at, you mentioned the EKG for like a heart doctor. So, you know, when you go into the doctor and you start talking about your symptoms, you know, is feeling this, and they ask, well, how many days, you know, and they want specifics, right? And you're like, oh, I just feel bad. And so
right.
gives you a platform for, you know, just really specifically charting these things. And then you have a map that they can understand and they can work with, and they're like, oh yes, you know, this is exactly what I
yeah.
Oh, cool.
And in addition, a lot of times when women haven't learned how to chart, like if you ask them, okay, what are your periods like? They go, oh yeah, it's every month. They're fine. And then they start to chart and it's go, oh wow, look at my luteal phase is short. My mucus, there's no mucus. It's like, there's all these abnormalities that even the woman like didn't realize was a problem. And yet then it starts giving verification to those feelings of, I'm feeling bad, no one believes me, but look, I've got concrete data. It shows I should be feeling this way. And so there's that verification, reinforcement that, yeah, she understands her body. She just doesn't know how to explain it.
That is an excellent point. Yeah. Yeah. Wow. Amazing. So the people are listening, like this all seems like a lot of common sense, right? And we touched on, we touched a little bit on, this is not general practice. This practice of reproductive health care that cooperates with and restores reproductive function, not just for having babies, but because it's healthy. You know, we want that system to be healthy for a myriad of reasons. Why is this not the norm?
You know,
maybe it's a little bit of history here, but what do you think?
It's the $1 million question, because anybody that understands it asks the same question, because it makes so much scientific sense. And it's like doctors should be based in science. And yet you can ask them, they go, oh, we don't believe women want that. Or, I mean, I've had so many different answers. And people like to bring it down to like just a quick answer, and there is no quick answer. So like the common one is, oh, it's the drug companies and money. And it's true. If you look at the top 5 money producing drugs in the world, synthetic hormones are in the top 5. So there is a money trail, but that's certainly not all of it, because, you know, the OBs, they really do want to help their women. And so I've asked some of my OB colleagues, and again, get very different responses. And some say, oh, you have to be OCD to chart. Women do not want to do that. And it's like, then you ask a woman who's charted and say, was this too hard for you? And they will look at you like you've just insulted them, because it's not rocket science. It just needs training. And so, you know, that disconnect of what doctors think women want and then what women really want. So I work UCSF, very secular setting. But for a while, I was the director of the primary care clinic. And yet I wrote into my contract, I'm not going to prescribe oral contraceptives. So when a woman would come in, and the residents, because there's always other attendees they can present to, but I think they just love to like tease me with this. And I'd go in and I'd explain to the women, okay, these are the complications. We can put you on the pill, it'll cover it up. But do you want me to empower you so for the rest of your life you understand your fertility? And they'd walk out there with a brochure to go learn how to chart. And the doctors would have their mouth open. It's like, I didn't think you could convince her to change. Like, women want this choice. It's just not given to them in a way they can understand.
Wow.
It's given to them like, oh, NFP is for parents, you know? And so it's just not true. Yeah. So, but you know, I still think there's more to it. And it's still, I think it's so complicated, you know, sometimes it's just changing culture is always hard. But it's such good news. You would hope that this would change faster for all of us who are, you know, in this journey. But yeah, I've had one of my OB friends said, when a woman comes to them and they say, I have to make sure I don't get pregnant because my husband would never abstain, and and he won't go along with this, and he's going to have sex no matter what, and so I have to be protected. And so she goes, so I have to give them something that's not under her control, but under my control. And obviously, you know, the whole thing with teens, how they like to use the long acting, like the depot shot, so the teen doesn't even have to take it. And it's really kind of makes you sit back. It's like, is that what we offer to women to protect them so that they can have an unhealthy relationship? You know, is that really the best that we're saying to be loved, you have to be modified? Because, you know, that's so much of what, whether it's the pill or the patch or the IUD, it's like, you have to be modified to be loved. And maybe we should be working on those relationships to really give a better culture. So it's so multifaceted. I wish we had a better answer.
Yeah, but it is important to talk about all those different pieces. And then the historical aspect, you know, we needed something reliable for family planning. And, you know, decades ago, it was just a rhythm calendar method, and that wasn't working. And then we had something that was a solution. And so now we're coming around to, okay, now this is a better solution. Let's really understand the bodies. And so, and this is exciting times. Oh, there's so much excitement around this and so much coming out, I think, in the mainstream, and doctors are beginning to see it. So yeah, thank you so much for your work. It's incredible. So Dr. Keenan, can you tell me, or tell our audience, what, for somebody who is looking for this kind of healthcare, maybe they're frustrated with the current experience they have with their doctor, or maybe they haven't even talked to their doctor about something they're feeling like is off. What should they be looking for in a physician that is going to respect maybe that they're charting their cycles and take that seriously, and they're looking for a restorative approach?
Yeah, it's I wish we could say that they were in every town. You know, it does take a little bit of digging. And so you would definitely want somebody that's gone through extra training, because it's definitely not taught in medical school. And so, and that training can take a variety of different forms. I think the one that is probably the most organized and lengthy is through the Creighton model and naprotechnology. But FEM has a very organized, you know, systematic approach as well. The Billings have a method. And then there's new ones that are coming along. I know Europe has kind of some different ones. So there are different ways, and sometimes just going to each of those websites and looking for providers. There's like for the last 10 years, I just recently kind of retired. I was the president of the California Association of the NFP, where we try to pull all the resources. And then there's a website there for those in California. But we do need kind of a national or international, which I don't think is really available, of kind of all the methods.
Mm-hmm.
But I think at first, asking their own doctor, because I think if doctors knew that women were really interested in this, they might consider going and getting some training. And that's what we need, is doctors to know women want it. And so that's always a good spot. And then they can look at, you know, kind of which of the training systems would fit in their schedule. And sometimes it's just a stepwise approach. But that's definitely something that for the International Institute of Restorative Reproductive Medicine, because we know that it's so hard to get that training, is we've started making it so people can, you know, through the Zoom webinars. We've got international conferences. We do webinars twice a month, sometimes more. We do conferences. We save all of them, so there's like a huge library. But we're also going to start some specific certificate courses so that people can come away, collect enough of these to kind of put together like a whole certificate program, so that then they can say, oh, I've been certified by this international body, that I've really taken the classes, and go on from there.
That's so incredible. And IIRRM is a partner of the Cycle Power Summit, which we're thrilled about. So you mentioned talking to your current doctor about this. Can you give an example of one or two questions that a woman could ask their doctor in order for them to really evaluate if they would consider this type of practice?
Yeah. And I think, again, the chart, a lot of them are very surprised at how detailed and how much physiology is on the chart. So I'd say bring your chart, even if you think that they aren't going to look at it. Open it up, and doctors don't like to feel stupid. So, you know, give them a little explanation, like, hey, this red is my bleeding, these white stamps or these blue stamps, whichever method you're using. This is my mucus, and look at, here's my interval, and I'm concerned about such and such. Go in with a question and say, it looks like it's too short. And I have to admit, because when I would have the doctors rotating, like the interns fresh out of med school, and I'd have a NAPRA woman saying, hey, look, my luteal phase is too short. And they're going, what? How does she know that? You know, and they would just get so curious. And when I would teach them kind of a crash course, harms of contraception, as well as all the advantages you can get through doing NAPRA or any other RRM method, they'd say, why isn't this taught in med school? And what was interesting is most of them, if there were women, they wanted to chart. If they were men, they wanted their wives to chart. And so I think we just need to get the message to them. They really are open if they see the science behind it.
Yeah. So you're talking about medical students who are saying, why isn't this taught?
Yes, absolutely.
Yeah. Just the exposure.
And it has to be taught right, because I don't use the word NFP when I first present it, because that already puts up the flag. But if you just say, look at this women's health science, they start seeing all these new things that they can gather from a woman's chart. So go in with that chart to their doctor and say, hey, I'm really interested in this. And if you would like to know more, even maybe go in some websites, because sometimes they would really like to just on their own, because I want to learn a little bit more, where can I go? The IRM is a great kind of pooling of different ones. And again, each method, whatever the woman is charting, she could give that method's kind of website as well. But I think if they can kind of peruse things on their own, they'll see how much science is there that maybe they weren't expecting.
Yeah, that's great. So don't be afraid to bring your chart into your doctor.
Don't be afraid.
Yeah, and just share the knowledge that you have. That's fantastic. All right, Dr. Keenan, thank you so much. At the end of each of our interviews, we're asking our guests for your number one cycle power tip. We're going to be able to combine all these into a special gift for our attendees. What's your number one cycle power tip?
Oh, by all means, learn how to chart, do it well, put it down on paper, because maybe you're thinking, oh, I know my body, I know I'm fertile these days, so I don't have to put it on paper because I know what it is. Or as soon as you pass the fertile stage, people stop charting. But even in that luteal phase, you're expecting it to be dry, it gives us hints about the body's physiology. And maybe 5, 10, 20 years down the line, maybe you'll be diagnosed with something that they'll say, oh, well, I wonder what your reproductive hormones were like. And you'd have that great record. And maybe even if it's not you, but just to the body of how much we could gain if more women charted. And maybe we'll start seeing patterns like for who's at risk for breast cancer. You know, there's been some evidence that maybe if that luteal phase is changing each cycle by a significant number of days, maybe that means a little more breast cancer, but that study is really small, but it has a lot of potential. Or ovarian cancer, so hard to diagnose. So maybe we'll see patterns if women start looking at it. So if women do get one of those cancers, that we can look back in history and then maybe help the next generation so that we can be more preventive.
Awesome.
So chart and do it well.
Yeah, chart and put it on paper. It's one of those, you don't know what you don't know, right?
Yeah. Or apps, you know, there's some really cool apps that are coming out. Put it down somewhere. Yeah.
Okay. Thank you so much for joining me, Dr. Keenan. It's been a pleasure.
You're welcome. Thank you so much. Have a great day. Bye-bye.